Good afternoon. My name is Agnieszka Sznyk. I'm representing Institute Innovo, and I would like to welcome our great audience and our distinguished expert on the first this year of our ONCOROUNTABLE, because it will be series of ONCOROUNTABLEs which we are going to conduct this year. And this event is organized because of knowledge sharing, experience exchange, and also to show you the best practice from all over Europe in the different oncology area. First of all, I would like to introduce and welcome our guest in the studio. Welcome Professor Adam Maciejczyk from Polish Association of Oncology and Lower Silesian Institute Oncology Center, Dr. Aleksandra Studer from Lower Silesian Oncology Center, Professor Beata Jagielska from Polish Coalition of Personalized Medicine, and Professor Paweł Wiechno from Oncology Institute, Polish Institute of Research. We have also our external guests, our great speakers from different European countries. So let me invite and introduce Professor Christophe Kastner, who is Clinical Director of CUH Outpatients from Cambridge University Hospitals from United Kingdom. Professor Hendrik van Poppel from Department of Urology at the University Hospital Geisberg Catholic University Leuven from Belgium, and Professor Lukas Lamberg, General University Hospital in Prague, Czech Republic. And our today event will be divided in two parts. In first part, we will listen to the keynote speech, and the second part will be followed by panel discussion. There is also interpretation, so if you want to listen in Polish, you can click the button under your screen and choose the language. And now I speak in Polish. Proszę Państwa, jest tłumaczenie symultaniczne dzisiejszego webinaru, więc jeśli Państwo chcą słychać polskiej wersji, proszę kliknąć na dole ekranu, znajdą Państwo przycisk tłumaczenie ustne. So now let's go to the first part of our event, and I pass the floor to Professor Adam Maciejczyk and Dr. Aleksandra Studer.
Thank you. Good afternoon to everyone, and we would like to present our recommendation, please.
My name is Aleksandra Studer. I am CCCN coordinator, so Comprehensive Cancer Center Network in Lower Silesian Oncology, Pulmonology and Hematology Center coordinator. First of all, in our opinion, there are three effective methods of organizing process and treatment in prostate oncology. Of course, organizing of comprehensive care. So not only the treatment, but the care is the most important, from the screening to follow-up. The second tip is creation of uro-oncological units with appropriate cutoffs of cases. It's extremely important to have high volume centers, especially in uro-oncological surgery. And of course, establishment of a network of a regional and supra-regional cooperation. In Poland, there is only one payer, National Health Fund, so there are no barriers to cooperate. As you know, fifth flagship from European Commission is to cooperate to create a European network linking national comprehensive cancer centers. And in Poland, we have our initiative since February 2019. We have regional joint action as pilot program to advance cancer control. We, as a Lower Silesia, were the first with the Holy Cross Voivodeship, and since November 2020, we have had declaration that it will be national oncological network in Poland. I hope from 2023. It's, of course, fully compliant with national cancer strategy. In Lower Silesian Oncology, Pulmonology and Hematology Center, we have structure areas that overlap. The division that connects the entire structure is, of course, management division with the head of the management division, Professor Adam Maciejczyk. We have, of course, general structure of our hospital and a small joint action because we will be new oncological hospital. We are new oncological hospital, but we will build a new buildings for our hospital. And of course, very, very important 3 joint actions in Lower Silesian Oncology Center. Fast oncology therapy since 2015 and since 2019, 2 joint action, as I said earlier, National Oncological Network, and since 2019, IPAC project. We are now certified since 2021 in general area as CCCN, as Comprehensive Cancer Center, and we are we have specific certification in colorectal and pancreatic cancer. Of course, the part of the general certification was uro-oncological unit. And the theoretical basis that are very important for us to build comprehensive cancer care. First, policy paper from CANCON joint action, Comprehensive Cancer Center Network set of standards, echo requirements for prostate cancer, and our quality book from National Oncological Network. So first of all, this CANCON joint action was extremely important with the policy papers with policy papers that have extremely important tips for prostate cancer. For example, do not initiate management in patients with low-risk prostate cancer. Don't routinely recommend proton beam therapy for prostate cancer outside of prospective clinical trial. Do not perform PSA testing for prostate cancer screening in men with no symptoms of the disease when they are expected to live fewer than 10 years. Don't perform PET or PET-CT and radionuclide bone scans in the staging of early prostate cancer at low risk of metastasis. It's really very concrete here, what should we do and what shouldn't we do. And next, it was our set of standards from IPAC project. It was general, but the part of the set of standards were requirements for uro-oncological unit. And next, our auditors. One of the auditor was Professor Alexandre Pelzer, who is a urologist. And on the website, on the ECC website, so European Cancer Center's website, we have a specific set of standards for prostate cancer. And we have also very specific tips about primary cases reporting, about quality indicators reporting, and about expertise, for example, in urological surgery. I think that we should say that we haven't reported these quality indicators, these specific quality indicators for prostate cancer in our certification, but we are familiar with them. And next, eco-essential requirements for quality cancer care with very specific tips, not only for urology, for surgery, but for radiation oncologists too, and for medical oncologists too. So we should have dedicated, for example, dedicated radiation oncologist for uro unit. And practical basis. Practical basis. Here we have the most important initiatives in National Oncological Network in our center and from IPAC project. And we have created one common call center for all urology clinics in the voivodeship. It was one of the best way to making appointment for the patients. And the second tip was to standardize MRI report in prostate cancer, and it was very important for our auditors from IPAC project. So we should have TNM staging in every MRI report, and we should have, of course, PIRAT scale too. We standardize our pathology report too, with of course grade grouping and with TNM stage. Next, there are our general indicators from National Oncological Network, and we have also specific indicators for prostate cancer. There were only 4, but I think the most important. And one of the very important experience from National Oncological Network, appointment and follow-up applications. Through, of course, online, through internet. I think maybe we should think about reorganizing follow-up for our patients. Maybe after 1 or 2 years, it could be conducted by our GPs, only with online consultation with oncologist or urologist. It will be it is very important for patients. And of course, our coordination, our development of comprehensive cancer care is through the people, through our team. On the left, our leaders from National Oncological Network, and on the right, our IPAC project team with Dr. Tupikowski, who is the head of our uro-oncology unit. Thank you very much.
Thank you very much. So now it's time to hear the United Kingdom perspective. So I pass the floor to Professor Christophe Kastner from Cambridge University Hospitals. Professor Kastner, the floor is yours.
Yeah, good afternoon. I hope you can hear me all right. I hope you can see my shared screen as well. Now, I'm a clinical director for outpatients at Cambridge University Hospital. I'm also the head of prostate cancer. We have a large department of 16 consultants, and we're divided into subspecialties, prostate cancer being one of them. Now, the recent changes, or recent over the last 15 years, of the prostate cancer diagnostic pathway towards the use of an MRI-based prostate diagnostic service have come in combination of a change of a biopsy method, that being from transrectal to transperineal approaches as well. And that obviously in itself is a combination of changes which have to be integrated. In addition, we've had the last 2 years of COVID, which have also brought up changes in how we deal with our patients in itself. So the pathway, not only in its tools, obviously also if there is an abnormal area, in particularly with a PIRAT or LICAT 4, we can expect an 85 to 90% detection rate from that. We do know that a low proportion of equivocal findings, PIRATS 3, is a good indicator of a good quality MRI. And the MRI also provides us with TNM staging. So this is just as baseline. This is not to educate any of you. I'm sure you all know that. But how do we get there? And this is a very honest slide here. We have started integrating the MRI for our prostate cancer patients in 2011, so a long time ago. Pirates as such didn't even exist, and therefore you can see Likert, the Likert scale terminology there. And in fact, we still use that today, but you can see this is our learning curve. This is groups of 70 or 50 patients over time, and you can see in green the 42% detection rate of biopsies in the positive MRI, and we used fusion technology there, so you should have been quite good at the beginning, versus the eventually achieved 81%, which is what the literature tells us. So it took us a long time to achieve that, and this is in a center where the radiologists are dedicated uroradiologists with an experience in reading prostate MRI. So this is something which needs to be recognized, that it doesn't come from nothing. There needs to be a learning and and eventually also a certification. And how can that happen? For us, it seems to be easy. We're serving the entire area of about 500,000 people as the urology center with our service. So we can, and we've got radiology, urology, oncology, pathology all in one hand. But health systems can look different. Like us, there can be an integrated practice unit, but there can be a tertiary referral center, a hospital chain, there can be an office urologist, an office radiologist. Everything can be different. How can we, as urologists or oncologists, ensure that our service is safe and what we are providing to our patients is safe? Now, obviously now after 11, 12 years of this development, the system has picked up in the last 5, 6 years. And the system is now providing, from the radiology point of view, some quality assurance certifications, training, which have to be assured. And here's, for example, one publication of a consensus of certification and reporting for MRI prostate, which my colleague Tristan Barrett, Professor Barrett, shared in the UK, chaired in the UK, and this can identify different levels of ability to read a prostate MRI. So we do get some external help, and obviously we need to see has my radiologist got that certification. There are therefore different measures we have to use as urologists to ensure our quality for our patients is good. It's like we just said, the MRI needs to be reported to a certain quality. They can use pirates or the Likert system, which is based on pirates but adds some expertise to it. As you've already shown earlier, the MRI needs to be reported according to a template. We've introduced that in 2013, quite early, to ensure that all that information is in it. And we simply have to record of that if an MRI is negative, equivocal, or positive. And as you can see now, I'm trying to go through what do we need to record to manage our quality. The biopsy technique should be standardized. There should be a standardized core distribution. I don't care which one. We are using the Ginsburg systematic distribution. And you need to send your targeted and systematic specimens separately to be able to distinguish what the quality is. You've also shown earlier that the pathology has to be systematically reported according to international standard to allow you to monitor. So to monitor your quality, you don't actually have to monitor too much. As I said, MRI, just negative, positive, and equivocal. And you should have a quality of an NPV of pirates 1 and 2, i.e. negative, for ISUP or grade grouping 2 to 5 or 0.85 or more. Your positive predictive value should be 0.7 or more, and the detection of reporting of pirates 3 should be around 10 to 15%. So this is not much. Anybody, any urologist can easily record that and then knows the quality. Now, we've already discussed a few issues here. We have a standardized MRI, targeted versus targeted and systematic. But what else do we need to decide on? That's what we stood when we went through the last 10, 11 years. That's what we had to decide. Fusion versus cognitive or visual targeting. Here is the evidence which is available. The one at the top being the most, the heaviest one, the best quality evidence. Essentially, in expert hands, there is no difference between fusion versus cognitive. But my position is, if you have a larger center with a high turnaround of trainees and a high volume practice, to standardize your practice and to shorten learning curves of trainees, the fusion technologies are hugely helpful, and therefore I would favor that. And we're running with 3 fusion systems in our hospital to provide a service of various levels of biopsies. If you don't do a biopsy, you need to trust your MRI, first of all. And also we have, because we started this very early in 2015, trusting our MRI, you need to record data. And as you can see here, with about 5 years follow-up in normal MRIs and discharged patients, the re-referral, re-MRI, re-biopsy rate, then finding significant prostate cancer is only at 2.9%, and the uptake of PSA testing was about 80% by the patients spontaneously. If we did a normal MRI and then had a normal biopsy, the detection rate of significant cancer in that group was 0% after 5 years. So this is quite reassuring, and therefore we have decided to carry on with this and trust our MRI this way. So as you may have heard here, it's all about trust. It's about the data. And I'm presenting this all casually now, or this is all what we're doing, and it's very high quality. Convincing everybody in the department and the team that this MRI is safe took years. And it did take that we recorded our data, our patients' data, and presented that to our patients. We have been moving away from trust biopsies over the last 3 or 4 years. We have been doing for 12 years general anesthetic template fusion biopsies, so high quality, high numbers. We introduced the local anesthetic transperineal biopsies. Now, we are in a process at the moment that my team has to start being convinced that these local anesthetic transperineal biopsies can be equal to those template transperineal biopsies. At the moment, they are not. And in our multidisciplinary team meeting, we are still being worried, sitting there, should we do a template one, do more biopsies, or can we trust this one? So this is a moving process, it's a dynamic process. It's not, you can't say, bang, we do this now. In particular in our case, where there wasn't actually the evidence from elsewhere there yet, and we were constantly running on the knife's edge at the front of the queue, you need to collect your data and dynamically change your practice and manage your quality along those lines. And that is quite an important message, this team-based approach, convincing on the basis of your data. And this is the problem we are facing at the moment. As I just said, we are now ending up with not just transrectal biopsies, easy. 12, 15 years ago, we've got those transperineal template biopsies, which we've been doing for 12 years. We suddenly have the local anesthetic transperineal biopsies with probe-mounted devices. We can combine all of them with fusion technology. And on the right in orange, you can see probably more up to date, what's called vector biopsies, where you can't even see the needle anymore. That's being guided by an electromagnetic sensor and guiding you to the MRI target in that way. So this is again a different move, which will be another step forward. So how are we all going to deal with this move into the future? And if you see here that the team approach is important, standardized imaging and reading. We do transparent biopsies. I think we should do fusion, targeted and systematic, quality assurance in place, and avoid biopsies if possible. These are all outcomes of our journey. But in essence, what covers everything is a team-based approach, and team is not only urology, it's radiology, urology, oncology, and pathology working with each other and critically assessing your quality at all and outcomes at all time, and having a quality assurance system in place. That is the key to a safe service to our patients. What I don't want as urologist is that after not having biopsied somebody, after 5 years, I sit there and he's blaming me that I haven't seen his bad prostate cancer coming. That is really important. We can only do that as a team. Thank you very much.
Thank you very much, Professor. So now we move to Belgium, and Professor Hendrik van Poppel, who is representing European Association of Urology. Dear Professor, please, you can start your presentation.
Thank you so much. I'm happy to be here with you. And first of all, I must say that I'm impressed by where you are when it comes to cancer centers of excellence, that you have made really the progress when we have been working on this issue with the European Cancer Organization. I want to thank the Polish Oncological Association and Adam Waśniewicz, who is working in Low Silesia, as I understand. Also, thanks to Innovo, to Hans Hofstraat from Philips, and I'm happy to see that in the panel later there will be Piotr Chlosta, my personal friend, as well as Iwona Skonetsa participating. I'm going to tell you something about the sad story of PSA and prostate cancer. You know, in 2003, the European Council has recommended screening for 3 cancers: colorectal, cervix, and breast, and we were at that time not ready to have prostate cancer included because of what you are going to be explained just in a second. I'm going to try to work. The connection is interrupted to change my slide. Okay. Prostate cancer is obviously the most frequent cancer, male cancer in the European Union. 1 man in 7 in general will develop prostate cancer. And the sad thing is that in 2010, as you see, 92,000 and something men died from prostate cancer. And in 8 years' time, this has increased up to 107,000. So my question is, what have we done wrong? And obviously, mortality is not the same issue in all places. You see here where Poland is. In Sweden, it's number 1 killing cancer in males. In Belgium, for instance, it's only number 9. So it's not the same issue, it's not the same problem everywhere because of this variability. But in the north of Europe, when it goes to the Scandinavian states, to the Baltic states, you see it's really a major killer. Now, if we go back in history, before we had PSA in the 80s, you see that about 1 out of 2 and 1 out of 3 prostate cancer patients that were newly diagnosed died of their disease before PSA became available. And in these graphs, you see where at the blue arrow, this is where PSA started to be used. And an immediate consequence was the overdiagnosis that is clearly indicated. This means that we have been diagnosed many cancers that we now realize should better not have been diagnosed because they were insignificant, indolent, as you might see. But you see that there is an increasing incidence over the years, getting more and more prostate cancer worldwide. And on the other hand, a couple of years after PSA was introduced, you see this decrease in mortality. Now, we know from the randomized trials, and I just quote those trials that I really trust. I do not speak about the American PLCO trial, but about the ERSPC, our randomized study. You see that after 11 years, there's a 20% reduction in death due to prostate cancer. In the Göteborg trial, 44% reduction in death after 14 years. And if you look at the Rotterdam cohort of the ERSPC, this is about 20 years of follow-up, you see that the metastatic rate decreases with 54% and the mortality with 52%. So do not listen any longer to those that still continue to debate that screening, organized screening, reduces prostate cancer mortality, because this is really an accepted issue. Now, if you look between 2005 and 2009, the changes in mortality, you see, look at where the bladder is, where the cervix is. The bladder we have made about no progress. But after initiation of PSA testing, you see that for prostate cancer, we have made the best decrease in mortality rates, and that actually no other cancer did better. But at the cost of well recognized today overdiagnosis and overtreatment. Now, okay, I am not able to advance my slide. Okay, because of this overdiagnosis and overtreatment, one could say that PSA has fallen victim of its own success, and testing was discouraged. And it started in the United States with the United States Preventive Task Force that really recommended against PSA testing. And it was said you will die with prostate cancer, not from prostate cancer. It's an old man's disease that is mostly indolent. And the problem was that in the beginning of our experience, prostate cancer diagnosis automatically led to treatment because we were unable to distinguish between significant and insignificant cancers. And in my own career, I know today that at least 15% of patients to whom I inflicted a radical prostatectomy should not have had a prostatectomy at that time. They should today be actively surveilled instead of undergoing active treatment. But for all these reasons, there was really an anti-PSA propaganda. But what has happened since? What is the consequence of all this? Again, I have. The consequence is that today, after lung and bronchus carcinoma, prostate has become the number 2 killing male cancer in the United States. If you look in the UK, prostate cancer death has increased by 17% in the last 10 years. Although our treatments are better, you see that today more men die from prostate than women from breast cancer. And nobody seems to be willing to initiate a prostate cancer screening program. If we look at Germany, number 2, after lung, prostate cancer kills more than colorectal. And there is a very nice study in Germany that they see that locally advanced prostate cancer at diagnosis was 29% in 2008. And because of the less testing, it's around 1 patient out of 2 in 2017. And we know that we cannot cure all these patients and that half of them are at threat of dying from it. And in Sweden today, prostate cancer is the number 1 male killing cancer. In the US, you see that more and more patients are diagnosed in a metastatic stage. This will mean not curable. This is patients that will become castrate refractory and will have a very poor quality of life. This is what we call a reverse migration. So prostate cancer is detected more and more in late stages. Over the years, look, between 2010 and 2015, more and more patients are diagnosed primarily with regional disease with lymph nodes or with bone metastasis. And you see that there's the brown line of prostate cancer. And you see that there has been always a decreasing rate in mortality, but this decrease has come to a stop, and there is now an increase of 5% per year. And we let this happen. This is absolutely not acceptable these days. And another thing is, if organized testing is not organized first, what happens today is what we call opportunistic screening, wild screening. What does it mean? A man is going to his GP and he wants to have a PSA tested, or a GP draws blood for one or another reason and he includes a PSA. And we know that this type of non-organized screening does not avoid overdiagnosis and overtreatment. And this is exactly what we want today. And it has no effect on prostate cancer mortality. So this needs to be stopped. So we have really reasons today to do something about it. And we have the possibilities because we are able to avoid overdiagnosis, because we use PSA more smart than we did before. There's the age-related PSA, PSA density related to the volume, the increase of PSA over the years, PSA velocity. We have the risk calculators. There's the American one, the Canadian one. There's the ERSPC that we mostly use, and there's the new molecular biomarkers, which we can maybe discuss later on. And then, most importantly, there is the MRI, the multiparametric, and probably in a screening setting, a biparametric MRI that is cheaper, takes less time, is less intensive. And this leads to a decrease in the number of biopsies. We detect more significant and less insignificant cancers, as also mentioned by the previous speaker. On the other hand, we can reduce the overtreatment because we know from nomograms who can be followed with active surveillance. And this is 65% of low and some selected intermediate cancer patients. Okay, what have we done? We have started by informing the patients and making a brochure. Shall I have my PSA tested? With all the pros and cons. Second, we have informed the healthcare professionals. There's the EAU guidelines that you all know that are endorsed by so many national societies. And finally, and the most important thing that I have been doing in the last years is to inform the policymakers. And I've drawn up 3 policy papers, the last white paper on prostate cancer, to tell the policymakers, and we went to the European Parliament, as you can see, to give them an advice on how to change this stupid situation that happens with prostate cancer. And we have had this publication in European Urology with recommendations for the European Union and the European Commission. And this is, we need to introduce organized early detection in well-informed men. And there is this information brochures that I just told about. And then following the age, 50 to 60 years or 60 to 70, and a certain PSA level. If you are below 1 or below 3, you go to a safety net when you're young and you come back after a couple of years. If you are older and you have a PSA below 1, you should stop PSA testing. It will reduce the cost. But if your PSA is higher than 3, you need to go for further risk stratification. And this risk stratification is very easily done with what we call the risk calculators. And you see them, they are available there. Even patients can assess their risk once they have their PSA, and obviously they have their age. And we will look at family history, at PSA density, use the risk calculators, BRCA2 gene mutations. But so immediately, the risk stratification will identify a percentage of guys that are just low risk and going clinical follow-up. The high risk, before getting a biopsy, will first have an MRI. When it's 4 and 5, they will finally go for systematic and targeted biopsies, as just mentioned before. And then of these, some will have grade group 1 cancers, and they will go for active surveillance. So the 3 main changes, the game changers actually in our policy, that make that elevated PSA does not lead immediately to a biopsy, like in the past. There's the risk stratification, there's the MRI, and there's the introduction of active surveillance. Sorry, I every time lose the connection with the internet to move my slides. So, and I think this is important when we talk imaging and when we talk the progress that we have made. What do you see that actually from all these men, that have a PSA above 3. Following, and we can calculate the number of them that have a PSA above 3. With the reflex testing, there is this percentage that is low risk. The high risk ones go for MRI, and finally, they will be risk stratified. And there's all this number of people, this number of healthy men that are not imposed any further diagnostic procedures, but the safety net with a control of a couple of years later. And you see that from these 100% that undergo an MRI, in the end, there is some that have prostate cancer, of which 1/4 will again, as I said before, go for active surveillance. So this is really the progress that we have made. And that recommendation to the EU Beat Cancer Plan from Ursula von der Leyen is that we will use PSA testing properly. Well-informed man, enough life expectancy, use PSA smartly, risk calculators, and MRI, important, most important game changers. Biopsy only those at risk for significant cancers, and give a radical prostatectomy or radiotherapy only to those who are at risk to die from prostate cancer, and manage with active surveillance. And again, a very important role for MRI to avoid these repeat biopsies. Those patients that in the end said, take my prostate out because I do not want to have biopsies every 2 or 3 years. But MRI will, again, there be the game changers in those patients with low and intermediate risk. And this way we will decrease the prostate cancer cost for the community. We will decrease the mortality and improve the quality of life. And just to give you an idea, when I speak to policymakers, they need to be aware of what is the cost of too late detected prostate cancer. And this is a typical case who in his 60s underwent surgery, probably for locally advanced prostate cancer. He needed radiotherapy, salvage radiotherapy a couple of years later for a PSA relapse, but then finally he's becoming metastatic and he needs castration. And you see the prices here, 10,000 euros. 11,000 once you get metastatic, and then there is all these drugs that we have today with the new coming radioligand therapy. So again, something that is very important to notice, palliative radiotherapy. But for this poor man that was diagnosed too late, our health services will pay 240,000 euros for this last 2 years for a very poor quality of life in a castrated man with all these toxic agents, a miserable life extended for 2 years with this high amount of financial cost for the society. So what will be the saving if the EU will recommend to the Commission and the Council that we start up this population-based organized screening? PSA will cost 10 euros. Multiparametric MRI, 136 in Belgium. I know it's more expensive in Germany, in France, but the biparametric is probably in a screening setting as good. And then early detected significant cancers to be treated, 10,000 euros. And what do we save? With the MRI and the risk stratification, we do less biopsies. We'll have less complications of the biopsies. We will have less treatments and less complications of the treatments, less overdiagnosis, no costly treatment of this castrate refractory disease, less prostate cancer deaths, so an increased professional lifespan and paying taxes, and better quality of life. So this is really savings that nobody today continues to ignore. The Europe's Beating Cancer Plan has been presented by Ursula von der Leyen early last year. And she has asked the populations, what do you think about screening? Do we need to extend screening to the other cancers? And in the EU policy that I'm chairing together with my friend Van Kerrebroek and our manager Sarah Cullen in Brussels, we have been lobbying and trying to make them aware of what we want. More than 25 years after the ERSPC, knowing the mortality data improved, more than 5 years after lobbying at European level, after the publications that we have had recently in European Urology Today, Nature reviews, working with WHO, and after our recommendations that an increased PSA does not lead to a biopsy, but we do risk assessment, MRI, and active surveillance. And they have heard what we said, because the scientific advisory mechanism of the European Commission, the SAPIA, the scientific advice for policy by European academics, after hearing a number of experts, have decided the following, of which actually we are very proud. They have told their strong scientific evidence for the benefits of organized prostate cancer screening using blood tests, particularly combined with follow-up MRI for men who have positive blood tests. So the intention is to extend the screening programs next to cervix, breast, and colorectal to PSA-based screening in combination with additional MRI scanning as a follow-up test. Good evidence that screening can reduce deaths from prostate cancer. So I think that finally we will get support. And I will just, in 2 words, and please do not communicate this, this is confidential information. In Lithuania, they are doing PSA screening population-based since 2005. It's on awareness campaigns, so it's not on invitation. And they reach today 50% of men. But look, very recently, 2 regions in Sweden have started what they call organized PSA testing. And you see the figures. This is the man 50 years of age in that area that were invited to come with an information letter. This is the number that turned up. So you see, it's lower than for the mammogram in females. Man will not go like females for early screening. Finally, 106 had an MRI. You end up with 16 prostate cancers and 13 were actively treated. So we have really an idea of how we have to do this, following the example of the Swedish. You know that in the UK there's a patient organization that is now in 4 areas doing this organized prostate cancer screening, as we have proposed, including the use of MRI. No, I'm sorry, I'm trying and trying again. That's one too far. Now, you need to know that the European Union for Health, the EU for Health call, is now allocating a grant of 10 million euro for prostate, but also for lung and gastric cancer, to investigate what is ongoing today, how we can have models for screening and adapting our screening protocol that we have today to perform this in pilot regions spread over Europe. And we can come back in the discussion if Poland has a role to play there, but I can tell you that we are seriously considering this. And we hope with the EAU and with a very strong consortium to get this 10 million euro to have things started really in the next future. I think that this thing to advance the slides, next time we need to change. In this PRAISE application, we have a top starter. There's a company that's running the thing. There's the EU guidelines. We work with the GPs. Through Wonka, we work with the WHO, the patient organizations, European Cancer Organization. And we are really hopeful that with the deadline of the 24th of May, so it's really very busy days for us now, that we can have this grant allocated and start things up in the second half of this year. I'm really aware that maybe I made it too long. It's also because the slides do not advance, but I thank you for your kind attention.
Thank you very much, Professor, for your very interesting presentation with some terrifying and alarming data as well. And thank you very much for mentioning this long-term perspective and indirect cost, which sometimes I think, decision makers are overlooked. So now we are going for the last presentation, Professor Lukas Lambert from General University Hospital in Prague, from Czech Republic. Professor Lambert, the floor is yours.
And gentlemen, first of all, thank you for a kind invitation, and I am very grateful for the good work the European Association, the Society of Urology does for spreading the word and for introducing new guidelines and new proceedings, how to select patients and for prostate cancer screening, and how to perform either multi-parametric and biparametric protocols. So, Professor Popel, thank you very much for your good work. My talk will be very short. I'm a radiologist. I do MRIs of prostate on a regular basis. And there are some issues that are still unresolved. First of all, what we encounter is various, very variable image quality across various centers. We encounter MRIs that come from outside that have very poor quality, and we have to retest them, make another MRI repeater scans before we dare to proceed to fusion biopsy. We have very good recommendations from the European Society of Urology. But if you apply these recommendations to scanners that are different than 3 Tesla Siemens, then it simply doesn't work. And I believe that the support from technologists and mutual communication across centers and sharing the protocols and experience would be beneficial for this. So this is a kind of protocol that we acquired from outside hospital, which has beautifully painted lesion in the peripheral zone. But if you take a look at DT2 images, they are hazy. So we wouldn't get satisfied with this. So mostly how we gain experience is by sort of trial and error. We have some basic knowledge how the system works. If we change one parameter, then we know what may happen if we change a different. But to do the interplay and tune the image to be the best at the shortest amount of time, it's really difficult. Take a look at what we have done. We learn piecewise from our colleagues that they no longer recommend to do more excitations, because if you scan the prostate not once but take a look at this plane, if you take one line and you intervene different lines, then when the patient moves, then you have image that skips between each slices. So this is one recommendation that we acquired by inquiring from our colleagues. Secondly,
Excuse me,
to use
Professor.
a
Can I interrupt you for a second? Because I think you don't
yeah.
share a screen. It's something wrong with the presentation. We can't see
Oh,
it.
Jesus. So I will stop sharing it, and again, we share it again.
Yes, yes.
Stop sharing, and so once again, can you see the screen right now?
Yes, now we can see it perfect. Thank you very much.
Wow. So we were hesitant to notice it. Thank you for noting this issue. So first
Now
of
it's
all,
working.
the image quality across. Thank you very much. The image quality across different centers, we have good guidance for scanners of one vendor, which is the most common, but we have worse guidance for different scanners. And there are some issues that we have to develop by communicating to our colleagues from different scanners. So first of all, what is recommended? Use more excitations, but finally we arrive at the conclusion that one excitation leads to the sharpest images. Use one package so that we don't have intervening scans between each other. We don't have scans that do scanning in every second line, and then the other. And when the patient moves a bit, then we have skipping acquisitions. Next, waterfall shift, which is another parameter that defines how sharp the images are. It's, for example, another issue because there is some certain amount that we have to use. But if you use very low water fat shift, very crisp images, but the signal is half or less. So finally, we arrived at this, that the water fat shift has to be maximum. TE time. TE time is something that should be the same among scanners, but it is not. We know, for example, that in Philips scanners, the TE time, the time to echo, has to be slightly longer than at Siemens scanners, which is another piece of knowledge that we have to acquire the hard way. TR time, this is the common TR time, and the matrix size. Now we know that we have to reconstruct these images into insanely large matrix, very small voxels made from large voxels that we acquire, and then it makes better and crispier images. Last, for example, the use of sandbag to compress the abdomen or some bending. So there are various experience. People say sandbag is good. Some say sandbag is not good. It introduces inhomogeneity. The use of spasmolytics we introduced last year. We were afraid of making difficult urination for patients with prostate hyperplasia. Fortunately, there are already some guidances that say that spasmolytics can be administered even in these patients. So these are issues that we encounter. We have little guidance, and we have to rely on experience of various centers. We have to communicate with different centers, play with the images, but there is no solution like the prepared protocols from the vendor that would make this kind of this kind of images. So if you take a look at this panel, there are 3 by 4. It's a matrix of different acquisitions and reconstructions, and this is the only way how currently we can tune the image. So we have to ask some volunteer to be in the scanner for 1 hour, for 1.5 hours, and do some different acquisitions. One acquisition 3 to 6 minutes, and then do different reconstruction and make a comparison. Then you applied it to the general population. Try, for example, the maximum is 2 acquisitions, different acquisitions because of time. The examination must be finished within half hour so that we can scan 2 patients in an hour. And then you you observe how it behaves. If it's good in lean patients and even in thick patients where the prostate is more remote from the coils. So this is how we proceed by trial and error with guidance and information that we have to gather from different colleagues piecewise. So this is an example. There is one image that has drive pulse that allows you to decrease the time, repetition time to about 2,000 milliseconds compared to 5,000 and more. And here you can see that the definition is slightly better with the drive pulse, but it didn't work out with in different patients. This is an example of comparison of TE time. So TE time, longer TE time means better contrast, but decreased signal to noise ratio. So here you can see better contrast, but slightly worse definition of the nodules here in the transitory zone compared to 100 milliseconds, where you see that these nodules are very well defined. But still, this is one patient, and if you want to have a stable protocol, you have to make for comparison 2 scans, 2 sequences that work best, and test them, apply them during an examination to other patients. So another example of different TE times. This is better a longer TE, which is better delineation of this nodule and better contrast. For example, in this patient with shorter TE time, 100 ms, which is the recommended time, the definition is very poor. Even the signal-to-noise ratio is not that great. What we try to develop, something that is not implicitly recommended by the European Society of Urology, is the 3D imaging of prostate. So we wish to add it in the second plane, so not the first plane as the actual, to have the 3D view of the nodule, so not just only one plane, but several planes at once. And here we struggle as well. So the size of voxel, we now know that in one plane it should be below 1 millimeter for these 3D acquisitions. So what we arrived at was 0.8 times 0.8 times 1.2. So it's an anisotropic voxel, but it performs best, but not in every patient. Once again, there is a huge heterogeneity. So we have to try to improve it. So these are examples of the 3D protocols. Some protocols have small field of view and use different acceleration techniques, and these techniques introduce artifact from the periphery to the center. So numerous issues and little guidance, what should be the best standard. This is an example from an outside hospital, 1.5 Tesla magnetic resonance imaging, where they use 150 milliseconds time to echo, which is much longer, and they end up with crispier images with comparison to other 1.5 Teslas. So we may try to increase the T time to echo, but still it's sort of doing your own protocol from scratch. Finally, we found out that some people use diffusion-weighted images that are the basic diffusion images, diffusion-weighted images, but some centers use DVI with background suppression. We still are uncertain what's better, but we stick with the recommended DVI without background suppression images. Lastly, the early detection in prostate cancer, as Professor Van Poppel already pointed out, will probably be based on the biparametric protocol. A protocol that should last about 10 minutes, including localizer T2, transverse plane, DVI, and the throughput should be about 4 patients an hour. For our population of Czech Republic, which is 10 million inhabitants, this would be a task to scan the whole population, which is in question, for 3 MRI scanners, which is nothing. So we can use 3 MRI scanners to cover the whole population. However, the bottleneck for this is diffusion biopsy. We stated that we are, as radiologists, are capable to increase the throughput in such a way, but the urologist said we can't increase the number of fusion biopsies. So at our institution, it's the bottleneck of the screening of the early detection program. And some off topic, we can do images of the whole body. And again, this is kind of PET-CT like image from diffusion weighted and T1 weighted images of the whole body. We would be very curious to see how it would perform compared to PET-CT in the detection of remote metastasis. However, there are still some technical issues with the image quality, and we still haven't arrived at the perfect protocol. Lastly, it's increasingly important to share our experience by teaching students, not by just sitting in front of screen and professing some knowledge, but by making our students, the radiologists, work on the problem to make their own diagnosis and then be corrected. And I'm happy to announce that in Czech Republic, we are dedicated to hands-on teaching, like the full hands-off teaching, not that you would have a long, let's say, lecture and then 10 minutes something on the screen shown to the whole publicum, but the unadulterated hands-on teaching where each participant has is his or her own computer and can solve his or her cases for herself. So this is from our latest venture here in Prague, which took place about a month ago, and we are happy that it had numerous participants who gained sufficient knowledge to spread it among the community, and we will continue with this kind of teaching this fall. So thank you for your kind invitation, and thank you for the possibility of being with you. And lastly, once again, my regards to the European Society of Urology, which does tremendous work in making some basic framework for us where we can catch and say this is the right way, how to proceed, who to scan, when to scan, and what to do next. So thank you very much.
Thank you very much, Professor Lambert. So now we have a very short break and we move to the panel discussion, the last part of our seminar. So welcome after a short break, and to the panel discussion will also join us Dr. Iwona Skoneczna from Maria Curie-Skłodowska National Research Institute of Oncology in Warsaw, and Michał Kempowicz, Government Public Affairs and Market Access Leader from Philips. So now I would like to maybe first ask Professor Paweł Wiechno from also Maria Skłodowska-Curie National Research Institute of Oncology about your clinical perspective, how you can see situation with prostate patient in Poland, what is the most important barriers, how we can optimize the patient path in this area of oncology.
Good afternoon. First of all, I would like to indicate that in Poland, prostate cancer is the most cancer in male population, and is also the second leading cause of cancer death among Polish males. Then I should also indicate that 5-year survival rate of prostate cancer patients is not good in Poland. Then we have a lot to do. And I think that the most important factor is to shift the diagnosis from the metastatic stadium of the disease into the non-metastatic localized prostate cancer. And I want to say that I am impressed with Professor Van Poppel lecture about the screening of prostate cancer. But I think that we will meet some problems with that. First of all, I think that to conduct such a screening, we just need to have center of excellence for prostate cancer with huge outpatient clinics. We need to perform multi-parametric MRI, and that is not easy tool. Then I think that the center of excellence is the best solution. And the second thing is that Polish population is not willing to follow the screening programs. We have some problems with cervical cancer and with women. And I think that men are more troublesome. Then I just worry about the screening program that you, Professor Van Poppel, proposed.
Thank you very much. So now maybe we can go to Dr. Iwona Skoneczna. What is your perspective from Polish market, from Polish patient?
Hello, good afternoon. It's nice to see you all. I think, hello, Professor Van Poppel, nice to see you. Okay, I think I agree with all Professor Wiechno said, but I would like to maybe add that we can increase awareness of prostate cancer, especially in younger population, because still in Poland, people think that the patient with prostate cancer is in his 70s or 80s. Still, I think not enough young men are aware that they can go for early prostate cancer detection. And I think with our limited resources, when the awareness is more, when they are more aware that there are methods of early diagnosis, I think they will go for that, a lot of them. So other thing is what I think that talking about local treatment for prostate cancer, I think we have quite good resources for this, and I think there's a lot of urological departments where patients can be treated according to the standards, and the same is for radiation oncology. Unfortunately, we still are lacking enough treatment options for patients with advanced prostate cancer. So still we have limited access for our patients, and sometimes, unfortunately, patients not in the perfect shape, like ECOG2, we may offer them a chemotherapy instead of new hormonal agents, for example, even if they are fulfilling criteria of recommendation for such a therapy. So also, again, for fit patients, we are not having option like a second-line chemotherapy. So so that's why results are not maybe very good in comparison to other European countries. But anyway, I think we are making big progress in this therapy. And also, we don't have enough medical oncologists, I think, so there is more and more difficult to get to the oncologist, especially who has experience in treatment of prostate cancer. So this is what I would like to say.
Thank you very much. So talking about the awareness, yes, and screening program, maybe now we can refer to that our abroad speakers, our abroad expert. Maybe first, Professor Poppel, do you, what about this awareness in your program? How we can attract or convince patients to really take part in this screening program? And also what is the situation in the other countries like UK or Czech Republic? Please refer later. So Professor Van Poppel, please.
But if you allow me, I would react to the points that Pavel Wiechno has just mentioned, and then to what Ilona has said. The first point of Pavel was about the centers of excellence, the need of it. And I'm absolutely sure that this need of cancer centers of excellence is there. And you know that the European Commission is working very hard in order to have this implemented. And as I just heard earlier from the first presentation that we had, I think you are indeed far advanced. Why do you need cancer centers of excellence? Not for screening. Let me be clear. We need cancer centers of excellence for patients, not for healthy men. There is, I think, a huge misconception. We need to try to not make healthy men patients if it is not needed. And when you remember what I have shown, the circle of people that are just in for follow-up, clinical follow-up, they are not patients yet. They do not have prostate cancer yet. They do not have low-grade or high-grade prostate cancer. So what you need for screening is an organized screening. So an area, a region, a city that has the database of all men, healthy men between 50 and 70, organizes that these men at their addresses, through their SMS, through their telephone, through their email, got an invitation to have their PSA sampled. This can be with a GP, this can be in a lab, that doesn't matter, but the result of it goes back to the organizer, and the organizer tells the patient, you are 50, your PSA is below 1, you need to come back in 2 years. You are 70, your PSA is below 1, never come back. Your PSA is above 3. We're going to do a risk calculation and we'll tell you what we are going to do. We need an ultrasound to estimate your prostate volume. Still, he's not a patient. But after that, after the risk calculation, and he needs an MRI, then he needs to go and see. He becomes a patient who is at risk to have prostate cancer. So I think this is a very important difference. But we need cancer centers of excellence. Why? Because once you have cancer, you need to be able to offer active surveillance to the patient. And you know, if you do not have cancer centers of excellence, the patient has prostate cancer. The urologist sees the patient and he will say, you have a Gleason 6 prostate cancer, you are 52, we are now going to do active surveillance. This means the patient is not going to be happy. We say he will want his prostate cancer to be treated. The doctor is not happy because he cannot do a radical prostatectomy, or the radiation oncologist would prefer to treat him because it's better for his income, it's better for the hospital. So this is why you need cancer centers of excellence, to really not have situations where patients are treated depending on the financial situation of the expert that sees them. The other point that Pavel has raised is the population not willing to come. This is a question that Iwona has touched upon. This is the awareness campaign. How do we make awareness? It's the social media, it's on TV, it's along your main roads where people drive to say, prostate cancer is not an old man's disease. Do you not want to die from prostate cancer? You can avoid it. But then maybe you need to have a PSA and maybe that's etc. etc. So this is the awareness campaigns. And then finally, it is indeed so that if you look at screening programs for breast, in some countries there is a turnout of more than 90%. This means that the target population, 90% is going to have their mammogram. But for men, this will be different. You have seen the slide from Sweden, and Sweden is, let's say, highly educated people, well-informed people. They know that it's the first killer in their country, and still there is less than 50% of men going there. And this again is awareness, and make really the healthy people aware of the fact that there is no reason today to die from prostate cancer. In Belgium, there is 4 men dying every day from prostate cancer. And I was recently in an important meeting with all the national societies, also with the Polish National Society. And from a huge country in Europe, not from the European Union, there was someone who said prostate cancer is so common and so few men die from it. Is this worth the effort of having a general population-based screening program? I said, when there is 4 men who die in my country every day, this is far too much You should not die from prostate cancer today. And it's not going to be costly if you compare to the cost that prostate cancer raises now if we do this in an organized manner. Then finally, Iwona stressed very clearly, young men are not aware. It's an old man disease. And this again, you need an organized program where there's invitations going to all men of a certain age category. This is the way we see it, exactly like in Sweden. And then finally, chemotherapy, local treatment availabilities. Okay, this is something that also in the cancer plans and in the cancer centers of excellence need to be taken care of. I'm absolutely in agreement with what Iwona said there. So if there is more questions, I'm willing to do or to answer what I can. Thank you.
Thank you very much. So maybe now, United Kingdom perspective. So Professor Kastner, could you comment on that?
Yeah, I don't want to repeat what Professor Van Poppel has just said, and I do agree that this is possible. But what I wanted to add to that is that we have to put into consideration that we must learn from what we managed to do during COVID. And in my hospital, 90% of the consultations 2 years ago turned instantly to remote consultations by phone or by video. And we still have a 40% rate now. After pre-COVID, we had 4.5% of remote consultations. So there are opportunities in remote management of patients and also patient-centered management where patients take over control of their health. We have a wide array of abilities of patients to manage their health. We have the one who knows more than you and me when they see us in clinic because Dr. Google has taught them so well. And we have the patients who really tell you, doctor, you know best, you tell me what to do. I don't really care, I'm quite happy to go to the pub and not think about it. So we have that range, and there will be various patients who can manage themselves and others whose hand we have to take. And but we also introduced here over COVID is a drive-through phlebotomy service. Patients come with their car, like at McDonald's, and have their blood taken, sticking their arm out of their window. And really, prostate cancer screening does not have to involve touching a patient if we are strict. So there are enormous cost savings in that area, but also operational, organizational savings, which compared to pre-COVID, we have to put into consideration, which makes this Professor Van Poppel's dream possible. We are planning here in the UK with Diagnostic Hubs, which include radiology, ECGs, any assessment, respiratory tests, but also blood tests. And the idea is that patients are being sent there to have their tests, and then first by phone or video, you communicate with them. We already have implemented here in our prostate cancer pathway MRI after referral by the GP before we see the patient. So when we don't see the patient, we phone them first. We talk to them about their history. We take a history. We talk to them about the MRI. And if everything is fine, we send them and say goodbye. If something is positive, i.e. MRI, and we need to do a biopsy, we see them just for that biopsy. We prepare them. It's expectation management, which is important. We tell them, with this MRI, you have a chance of 85, 90% of having a cancer. That means your biopsy now may be positive. So when we are meeting again, we talk to you about potential treatment options. We do that conversation about the result in these prime patients on the phone. So there are possibilities, even when it then moves into this cancer center situation, and the cancer center may very well be an hour or 1.5 hours away from the patient. There are opportunities to make this possible. So we need to go away from the standardized thinking to make such a screening program possible. And we know it is possible. I even go one step further with MRI prostate light version, which could be included in a screening program even further, but that's still something potentially to come. So I hope that's a good overview what can be done of what can be done. Thank you.
Thank you very much. So maybe now, what is the situation in Czech Republic, Professor Lambert?
Hello once again. Afraid I'm a radiologist, as I already told you, so I'm not good much for this kind of discussion. But we have discussed it in the Czech Society of Radiology, and we believe that the response rate from men for screening of prostate cancer will be much lower indeed than for screening for breast cancer in women. But we think that the campaign should be targeted not only to men, but also their spouses who are more considerate about the health of the other. So this may be a communication strategy. Secondly, I gain a lot of information from you, like that you perform the consultations on the phone, which is still not established in the Czech Republic. So every patient who comes for some positive or equivocal finding for mammography has to come there. The patient is invited, and then she has a consultation with a radiologist who will then instruct her that there will be a need for biopsy or something else. So this is one more step forward in making the system efficient, and I will propose it with the Czech society. And the third question, which I would like to ask the forum, is what is the age where you should start screening the unselected population for prostatic cancer? Is it 45 years when the incidence is extremely low, so the return of cost is not that great? Is it 50 years, or is it even 55 years where the curve starts rising sharply? Thank you.
Thank you very much. So talking about the cancer centers of excellence, we have here a great ambassador, I think, of the systemic approach, Professor Maciejczyk.
Thank you for this question, for all presentation. It's very interesting. I know that the most important for us, also for our excellent organization, is to connect all of these aspects. We need, in my opinion, we need to introduce unified standards in all Europe. I hope it will be in the future. Standards for management of our patients with prostate cancer. All these standards must be enhanced by measurement of our indicators. All indicators, not only connected with our diagnosis, for example, fusion with biopsy with MRI, or measurement of quality of our treatment, but also measurement of prophylactic aspects. Because we know also on example of breast cancer that this quality of this prophylactic procedure are also not so good when we compare this between different centers. So in my opinion, we need this unified standards and thinking about all pathway of our patients from prophylactic to follow-up. And of course, this center of excellence, it's dedicated for patients with prostate cancer, but to make a biopsy with fusion of MRI now is not popular in Poland. We did it in our centers from many years, but in my knowledge, it's only in my center so popular. So it's not now in this fusion, which is very important, as you know, in your proposition we talk about this. this fusion is must be better connected with all aspects of our diagnosis of our patient. So in first way, we have to think about this pathway. Thank you.
Thank you very much. So maybe let's give the floor to Professor Beata Jagielska. And prostate cancer is also side effects, yeah?
Yes, of course. And I think in this place the most important observation is that certain percentage of the patient with the prostate cancer die of other causes than cancer. So this is metabolic disorder, this is the cardiac disorder. So for us it's important to think about this patient that they need some systemic care. So we now discuss about the excellent cancer center. So in this center should be not only diagnostic and the treatment place, but also the place for the supportive care. It means supportive care for the cardiac disorders, so like cardiac systemic care. I think that the prostate cancer is the next cancer that cardiotoxicity plays a key role, understood as the distant complication. About cardiotoxicity, we think that this is the most important comorbidities in the breast cancer patient. But I think that prostate cancer patient is the next cancer that we should think about this patient, that they will need this kind of the care. Thank you.
Thank you very much. Today we also talk a lot about the coordination, about the teamwork, about multidisciplinary approach. So Dr. Studer, who is working in that field, have some experience. Could you share your perspective on this cooperation?
Yes, I think that one of the most important thing for comprehensive cancer care is to create units, to create a center of excellence, to cooperate. In some cases, we have comprehensive cancer center with urological surgery, with radiation oncology, and with medical oncology. But sometimes it should be in such way that we have, for example, two centers: one surgical center, center of excellence, and center that have medical oncologists and radiation oncologists. But we know that the best care is when we have dedicated multidisciplinary team with dedicated urologists, with dedicated for prostate cancer, with dedicated medical oncologists and radiation oncologists, with, of course, brachytherapy department, and we need dedicated pathologists and dedicated radiologists too. Of course, the whole multidisciplinary team is with nurses, with physiotherapists and psycho-oncologists. So I think that the key success for this is to have multidisciplinary team. To know how can we know that the team is the best? We need quality indicators, we need data about the expertise, about high volume centers, and we need, of course, primary case approach, because we have to know that how many primary cases, how many recurrences we treat in such center. Of course, I think that we should create such centers of excellence units in Poland. Probably it should be not only for prostate cancer, but it should be uro-oncology unit. So unit for prostate cancer, for bladder cancer, for kidney cancer. Thank you.
Thank you very much. We have with us also Michał Kępowicz, the Philips representative, medical devices, quite crucial.
Thank you, Agnieszka, for giving the floor. So I have three short thoughts. So I couldn't agree more with what Professor Popper mentioned about the key role of MRI examination. We have to think about and use these methods broadly, because it gives us quick and accurate answer, and it is safe method. The second, I can be also echo for Professor Maciejczyk opinion about the development, the need of development excellence center, but also the creating the standardized procedure for prostate cancer patients across European Union countries. But what more from Philips' perspective as a company which provides advanced medtech solutions also for oncology area, it is also very crucial to co-create holistic platform of cooperation between different stakeholders, between different level of diagnostic and treatment process. What we see on the basis of various projects, various initiatives focus on oncology. Digitalization of this answer gives enormous effects, and digital connecting the clinical dots in this sometimes defragmented clinical worlds allows smooth and seamless distribution of information, to have on the one screen all necessary information and data. One screen where we are collecting and presenting all necessary critical data significantly support clinician, but also help to create effective digital tumor board. So the digitalization of pathways, the patient pathways, but also different diagnostic methods in one streamline can be the right answer on challenges of clinical oncological environment.
Thank you very much. And now, as we're going to the end of our event, of our ONCOROUNTABLE, if any of our distinguished experts would like to add something, maybe Professor Van Poppel, like takeaway message from the European perspective?
No. If you want me already to give takeaway messages, I have heard a couple of things that I will try to reply to quickly. First, there was Lucas Lambert from the Czech Republic, who had a very specialized question on the age. Well, we speak, when we do screening, we speak about an unsuspicious, healthy male population. It's different when you are African American, when your father or your brother died from prostate cancer, when there is BRCA2 gene mutations, when there is breast cancer in the family. These patients, probably, these men, should be starting earlier. But this is not the general population screening that we aim at. What the Commission wants, and I think they're going to be very strict about it, is from 50 to 69 or 70 years of age. Because it's going to be population-based, everybody's going to be invited. So I believe that correctly, we should start earlier in patients that we know beforehand that they are at risk. I hope that this answers your question. Excellent suggestion to, in awareness campaigns, involve the spouses of the patients. Because it's the lady, the woman, the spouse of the patient who sends him to a urologist. Because she heard about screening. She sees how many times he wakes up at night, and often for benign prostatic hypertrophy, they also send their patients to the urologist. So information campaigns that will reach the spouses, indeed, Dr. Lambert, is very important. There was Adam Maciejczyk, who said on the prophylactic aspects, and I think this is completely right and is in line with what the Beat Cancer Plan is aiming at. They have actually three pillars. The first pillar is prevention, the second is screening, and the third is life after cancer. And this is indeed important that we do not only think about screening strategies. Prostate cancer, unfortunately, is not preventable. But when it comes to exposure to toxic agents, to smoking, to tobacco, I think this is where prophylaxis and prevention is certainly more important than screening. Then there was a question from Beata Jagielska. Prostate cancer patients die from other disorders. This is I'm absolutely convinced that many prostate cancer patients die from something else. But many of them die from cardiovascular disease, as you just highlighted. And just recently on the last EAU, European Association of Urology Congress, we had a whole session where actually every man that goes to androgen deprivation therapy should go and see a cardiologist. For me, this is mandatory. This should be done in order to avoid that because of the drugs he got, he's gonna die from his heart. Because then people say, you see, he died from his heart. He did not die from prostate cancer. Prostate cancer is not that dangerous, but it's actually the treatment that is cardiotoxic. So thank you very much for having realized that. Then finally, Alexandro Studer again emphasized on the comprehensive cancer care center. I know the Lower Silesian Center. You know that we are planning to do a couple of pilots in Europe, and that we are working with Christophe Tupikovsky, that we are working with Dorota Dudek-Rodot in order to see whether we should consider to have a pilot run in that area around Wrocław. The dedicated MDT is absolutely, you cannot treat a patient as a monospecialist any longer. And I would add, if you allow me, Alexandra, to the long list of specialists, the psychos, the nurses, the medical, to add the nuclear medicine that are coming into the game in prostate cancer much more now with diagnostics like the PSMA PET CT, PSMA PET MRI, and then with the radioligand therapies with the lutetium. So these already nuclear medicine people are sitting now in our multidisciplinary teams already as from today. The digitalization that Michal Kirovic was alluding to, the big data, the artificial intelligence, this is absolutely the way to go. And be reassured that also the European Commission is going to put a lot of money in the digitalization of the data heaven, the European health data space. And this is going to be an enormous progress for all the European Union citizens. So I did not summarize, but I leave the summary up to someone else from your panel, if you allow me, and I'm going to shut up now. Thank you so much.
Thank you very much from this great comprehensive summary, Professor Popper. We are really impressed here. Listen to your comments and remarks. So any of our experts would like to add something? I know it will be difficult after such a great speech. Maybe our online experts, Dr. Skoneczna maybe, or Professor Lambert. Do you want to add something?
If I may
Very
say,
grateful that you included me in
Dr.
this
Skoneczna
round.
first.
Sorry.
So maybe Dr. Skoneczna, if I can make it kind of in line.
Thank you very much for your initiative, because I think the exchange of such thoughts is very important for us to support our thinking and developing good strategies together with other European countries. So I think this is of great importance, and for sure I think it's much cheaper and from the economic point of view, and less adverse events when we find earlier prostate cancer. So I think this is, we really should try to change the pattern of stage in Poland. And of course, all aspects of treatment and complications, and also avoiding some treatments which are not necessary. This is everything. It's very important. So it should go together with education of our oncology specialists in every field. So thank you again for this initiative.
Thank you very much. And Professor Lambert, the last comment?
Finally, I would like to thank you all for sharing your experience. I personally learned a lot from the wide area of urology and prostate cancer because I just focus on one very narrow scope. So thank you for including me, and I hope that also the auditorium derived much utility from this panel discussion. Thank you very much.
Thank you very much. And how we, I think, end our discussion about prostate cancer. But as I said, it is first from our series of ONCOROUNTABLE. Next time we will meet you, I hope, in Wrocław, where we're going to talk about liver and kidney cancer. And after holidays, we are planning to go to Czech Republic. So Professor Lambert, but this time we are going to talk about the lung cancer. So I already welcome you to follow our events and be with us. And for now, thank you very much. Thank you, our great experts, to share your knowledge and experience. And see you soon, I hope. Thank you.